Hello, my name is Naresh Bumma. I'm a hematologist specializing in multiple myeloma. I work at The Ohio State University Comprehensive Cancer Center, and I would like to talk to you guys about the bispecific antibody Regeneron 5458. We have presented some very exciting data here at IMS 2022, and I would like to share that with you. So to start off, first, what is a bispecific T-cell engager antibody? So I want you to think of it that there are two antibodies that are linked together by a chain. One of them is going to be against CD3, which goes and engages a T cell, and one of them in this case, will be against BCMA, which is a surface marker found on myeloma cells. Now, what that does is that it connects those T cells and brings them together. And the goal of it is to activate the T cells, which then becomes active, recognizes the myeloma cell, and kills it directly. And that approach has been used in other diseases as well, and is getting a lot of traction in multiple myeloma. So there are multiple different compounds with a very similar mechanism of action that are available under investigation, and the one that we'll be talking about is Regeneron 5458. So this is a antibody that is infused intravenously. We do this in the IV every week for 16 weeks, and then every 2 weeks afterwards till disease progression or till the patient decides to come off the treatment. The first two doses are given in the hospital, and it is a step up dose. And the reason for doing that is that we want to mitigate the risk of a condition called cytokine release syndrome. Now, what is cytokine release syndrome? So, as if you remember, I mentioned that we activate T cells, and that causes your immune system to wake up. Now, in some cases, it can wake up a little bit too much and become extremely active and causes cytokine storm that presents with symptoms such as fevers, chills, rigors, low blood pressure, and so on. So, with to prevent that, we use the step-up approach, given two doses in the hospital. So in this study, what we found is that in a heavily pretreated population, and the majority of patients in this study had at least 5 prior lines of therapy, we had a very good response rate with every overall response rate of 51%. And as we went higher on the doses, we found that the response rate was significantly improved to up to 75%. And out of those, more than 60% had a very good partial response or better. And 4 out of 10 patients were found to be MRD negative. Now, in terms of safety data, what we saw is that the risk of CRS in this specific cohort of 73 patients was only 38%, which is much better than a lot of the other bispecifics that are out there. If we look at the neurotoxicity signal, which is also seen in other conditions, we've seen only 3 cases of grade 2 neurotoxicity and no grade 3 or grade 4 neurotoxicity. So that was very encouraging to us. We did, however, see some infections for which we have amendment protocol to take measures to prevent. So this is it causes safe and early and deep durations in patients with relapsed multiple myeloma. And this new therapy will hopefully be studied more in a phase 2 study and in combination with other therapies, and will become part of the treatment for multiple myeloma very soon.